morning. My name is Katie McMillan. I'm the asthma social worker at Children's Hospital of Alabama. I am glad to be here with you guys today, and we are going to spend about an hour talking about asthma. We have four main objectives in this. We're going to first talk about the scope of the asthma disease burden. Then we're going to move on to the actual disease process, the symptoms, the various medications, and how to use those correctly, and how to empower patients to use their action plans for home management. The third thing that we're going to talk about is how to identify common asthma triggers and help families make accommodations for these in their homes. And finally, we're going to talk about the special role of the case manager in asthma control. So why do we spend so much time? Why, of all of your training here this week, do you spend a whole hour talking just about asthma? According to the National Health Institute, more than 22 million Americans have asthma, and an estimated 6 million children are affected by this disease. In 2007, the National Survey of Child Health found that 12% of Alabama's children ages birth to 17 currently have asthma or currently being treated for asthma, and that 17% in the same group have been diagnosed at some point in their life with asthma. The Agency for Healthcare Research and Quality found that asthma results in approximately 13 million missed days of school each year. And as social workers, we know that for every one of those missed days of school, there's likely a missed day of work, and that can put really significant burdens on families. The leading cause of hospitalization and ED visits in children is asthma. In 2004, an estimated 300,000 U.S. children were hospitalized, and the cost of this was more than $2.4 billion. The ED costs alone related to pediatric asthma in that same year were over $280 million. So that is why we're talking about that, because this is a disease with a huge scope that impacts a tremendous number of people. When you're talking about 12% of the state's children, that's a tremendous number. The next thing that we're going to do is move into the asthma disease process and the medical management of it. Okay. So according to the National Heart, Blood, and Lung Institute's Expert Panel Review 3, which was done in 2007, and which is the basis of all the information that I'm going to give you today, they define asthma as a chronic inflammatory disorder of the airways characterized by variable and recurring symptoms due to the following: bronchoconstriction, that is where the muscles in this airway that surround the tube constrict, so they clamp down. Can we go? Airway hyperresponsiveness is the second criteria, and that just sometimes you'll hear it referred to as a twitchy airway. That the people with asthma's airways are much more sensitive, so that when they come in contact with an environmental trigger, it sets this immune process in the immune response in process. And the other thing that characterizes asthma is airway edema or airway swelling. If you look at this right here, this is a model of a healthy airway. The opening is it's like a pipe. Easy to move air in, easy to move air out. But if you look at this model represents somebody with moderate persistent asthma. And if you can tell this, this is this nice pink, light skin, not irritated or inflamed. But when you look at this, it's red, and you can tell that it looks kind of angry because it is so irritated. As the muscles clamp down, the nice big pipe that you have starts to close off, and it's more like a straw. And that swelling can be present all the time, and that's one of the ways that physicians work with medication to try and control that swelling so that you're closer to what a healthy airway looks like. But when you come in contact with those triggers, the hyperresponsiveness part, those muscles clamp down. And if you've already got the swelling here, then it's kind of like taking so you should have a pipe. The swelling takes it down to more like a straw. And then when that clamping down happens, the effect is that you're pinching off that straw, and you're trying to draw air up out of that pinched off straw. And that can be a great illustration for families and children, because that's an easy way to understand it. And this is just a bigger picture of what happens. You take the air in. The disease is not of the soft tissue in the lungs, it is of the airway. And that's what that slide is showing you. Again, one of those is a healthy airway, the big pipe. The other side is the inflamed asthmatic airway. You also produce, your body starts to produce a lot more mucus when this response starts, and that also makes it difficult to breathe because that's making that already tiny airway even smaller. Okay. So we're going to talk about asthma symptoms now, but we're going to talk about them in terms of early warning symptoms, common symptoms, the ones that we most likely to associate with asthma, and then we're going to talk about some of the more dangerous symptoms of asthma. Cough, wheeze, chest tightness, and waking up at night are sort of the hallmark symptoms of asthma. These are the symptoms that you're most likely to see at the beginning of an asthma flare-up. And it's important to know that a lot of people with asthma, the only symptom that they ever have is cough. Before I started doing this, and most of the family members that I ask, wheezing is the symptom that they associate with asthma. But there's a large number of asthmatics that coughing is their primary symptom. Later asthma warning signs, breathing is hard and fast. You may notice that the patient's nostrils are flaring, that their ribs are showing when they're breathing in and out, that they're having difficulty walking or talking. These symptoms require prompt treatment. If they're not responding quickly at home, this would be where you would need to seek either treatment in a physician's office or in an emergency room. And then there's a subset of symptoms that are life-threatening. If a patient can't speak at all, if you notice that they're sweating, if they're tripoding, which is leaning over, bringing your body forward to try and open up your airway as much as you can, changes in color, if you notice maybe not just their ribs are showing, their neck's pulling, they're really using all of the muscles in their abdomen to try and move that air in and out. These are examples of life-threatening symptoms. If you were to go into a home and you notice that, you would want to call 911. Hopefully a patient, by the time they got to this point, would already be in a healthcare setting receiving treatment. Okay. Asthma exacerbations or flare-ups can be mild to severe. Most mild flare-ups can be handled at home or even at school. If they're out for physical education and start to have symptoms, they're able to go to the school nurse and with quick relief medicine turn around. Or parents are able to do that, so they wake up at night coughing and are able to get on top of that and treat that at home using their action plan. Moderate flare-ups, more of those later warning signs but not the life-threatening ones, those more likely need to be evaluated by their primary care physician, or if that's not an option, an emergency room setting. Severe exacerbations are ones that almost always require emergency room treatment at least, and that oftentimes wind up in hospitalizations. And that may be a common time for you guys to get called in when a primary care doctor realizes that this child has has had 2 or 3 hospitalizations, and, what's going on? Is there something that we could be doing differently with this family? Within the group, so if you've been in the hospital because of asthma, you've demonstrated that you have pretty significant disease. Within the group of hospitalized patients, again, there's a subset of children and adults that truly have life-threatening crises that end up in intensive care admissions, and these people are much more likely in the future to suffer from life-threatening exacerbations and statistically are much more likely to die because of an asthma exacerbation. So if you notice that has been a course of care in your patients, that's just a warning, a flag for you to know that person's future risk of death because of asthma is increased. And these are the life-threatening exacerbations are the ones that can result in respiratory failure and death if not aggressively managed. Okay. So there are 2 types of asthma. There's intermittent asthma and persistent asthma. Intermittent asthma are the patients that, once or twice a year, they might get a cold and that starts this response. Or they may have an exercise component of asthma that when they're out running, they have symptoms, but it doesn't really affect their day-to-day functioning. And it is controllable with just quick relief medicine to treat symptoms once they've occurred. Within persistent asthma, there are mild, moderate, and severe persistent asthmatics. And all of these people, and increasing as you go up the spectrum, but have some level of daily function that isn't affected by their disease. And these patients do require daily medications to try and control that inflammatory response that is present in their airways. Individuals with intermittent asthma require quick relief medicine fewer than 3 times a week. That's kind of how that clinical judgment is made. So they're not reaching for their albuterol all the time. It's not a daily thing. But for many of these people with intermittent asthma, it's not 3 times a week. It may be twice a year or 3 times a year that they use it three times in the week. It's really they just have a few flare-ups a year. And those are the common things that are used to measure the severity of persistent asthma. How often, let's see, is it interfering with their sleep? That's a big one, especially with kids. Are they being prescribed frequent oral steroids to treat their asthma? That's another one. How often are they having to use quick relief medicine? Those are kind of the big things that physicians look at, and we'll see a slide in a second that show that a little clearer. And this is it. If you can see this just shows the things that the doctors are looking at to establish control. And I just this is right out of the EPR3, and I just put this in there so that you would know that it does exist. You can Google it and find these charts, and it's not something that you need to memorize, but if you do have a patient that you have questions, something doesn't make sense, it may be worth it to look at that and kind of see how that diagnosis is established. Let's see. We use a stepwise approach. Once a patient is diagnosed with asthma, they're looking at how the degree of control that they have of their disease, and this chart shows you, although I'm not sure that the slide came out with all of it on there. Well, again, if you were to look the slide up from the EPR3, it would show you the different categories that physicians use to determine control. Once a severity is judged at the beginning, after that initial diagnosis and a treatment plan is made, then they're looking at control instead of severity, and that's what these show. So there are 2 main types of asthma medications, and that's what we're going to talk about next. Any of you, do you have any questions about the disease part? Okay, we'll move on to medications. The most common asthma medications are quick relief is what we call them, or short-acting beta agonists. These are used to treat acute symptoms, and their job is to relax when these muscles start to clamp down. Their job is to release those muscles, to help those muscles relax. So the muscles inside the airway, the short-acting beta agonists will work to release those. Typically 5 to 10 minute onset, so it's pretty quick treatment onset. Controller medicines, these are most commonly inhaled corticosteroids. There are also combination medicines of long-acting beta agonists and inhaled corticosteroids, and then some alternative therapies. These are used in people with persistent asthma to try and control this chronic inflammation every day so that their airways are less inflamed and more like somebody without persistent asthma, so that when they do come in contact with their triggers, their body's prepared for it and can handle it better. So it's really important in quick relief medicine that everybody that has asthma has access to that medicine. Anybody with any, even if it's intermittent asthma and they haven't had a flare-up in years, they need to have access to that, to quick relief medicine, because that is what, when an attack starts, that's the medicine that's going to help relieve those symptoms. These are examples. Let's see. The next three, ProAir, Ventolin, and Proventil, are all three brand names of albuterol. Albuterol is the most common quick relief medicine. About 5 years ago, the EPA said that they had to start using a different chemical to force the medicine out. And at that time, drug companies took that as an opportunity to rebrand albuterol. So now we have these three different puffers that are all really the same medicine, and that can be very confusing to patients. Xopenex is levoalbuterol. It is also a quick relief medicine and a chemical cousin to albuterol. And Perbuterol, or Maxair, it works the same way as the other two. It does not require a spacer to be used with it. It's breath activated, and it's the only one that has not had to change the chemical that forces the medication out, because there's no other device like it. So at least through 2013, it'll be available. And a lot of teenagers like this because it can just go in your pocket. You don't have to have a spacer with it, and we'll talk about that in a minute. Okay. So this is the stepwise approach to therapy. Once a patient is diagnosed with asthma and the level of severity is established based on how much of a disruption the disease is, how often they're waking up at night, how often they're getting systemic steroids, how often they're using their quick relief medicine. The doctor will figure out where on this continuum they are, and then that sort of lays out the guidelines for what medication regimen the patient should be on, or what combination of medicines the patient should be on. And then at follow-up visits, when they're assessing control, they'll move that patient either up or down the continuum depending on how well the regimen is working for the patient. So types of controller medicines. So now we're going to switch and talk about controller medicines. These are given every day to try and control that inflammation. So this is, when you're talking about this, now this is just the persistent group of asthmatics, not the intermittent asthmatics. The most common and the most effective controller medicine for both children and adults are inhaled corticosteroids. That's like Flovent, Asthmanex. Those are examples of Pulmicort. Those are the examples of inhaled corticosteroids. The next line of defense in somebody for whom an inhaled corticosteroid alone is not enough is an inhaled corticosteroid plus a long-acting beta agonist. So that would be like Advair or Symbicort or Dulera. Those are examples of those. There are some other things, leukotriene modifiers. Singulair is the most common in this group, but Zyflo and Accolate are both also in this. They work, leukotrienes are similar to histamines, but you have a much stronger response. So if that is what causes the patients to have severe flare-ups, that can be really helpful. A lot of times they're used as adjunctive therapy too. Immune modulators are much less common. Those are usually undertaken in the doctor's office. I'll show you an example of them, that they're injectable medications. And then systemic corticosteroids. There are a few patients at the very most severe end that will take oral steroids every day. These are just older asthma medications. I put them on here so that you would, if they come up, that you would know that they can be used, but certainly not common. These include mast cell stabilizers, which are acromegaline and nidacromil, and anticholinergics, which are Atrovent and Spiriva. Those are much more common in your COPD populations. And then the methylxanthines or theophylline. So like I said, the inhaled corticosteroids are the most effective forms of controller medications for most patients with persistent asthma. The goal of these medicines is to control the inflammation in the lungs so that when they do come in contact with the trigger, their airways are more open and have more room to work with. They come in a variety of forms and strengths to meet the needs of patients on that continuum. And these are examples. Flovent, you can see it has a counter on the back. It starts, when you first take it out of the package, it starts at 124. You prime it 4 times, it goes down to 120. It's typically dosed, most of these are 2 puffs twice a day. So that's exactly, the 120 puffs is exactly what you need for a 30-day supply of medication. These are just more examples of inhaled corticosteroids. And really, I just want you to have these so if patients have them, you can have something to reference. Pulmicort is the only nebulized inhaled corticosteroid, so you'd be most likely to see this with either very young children or maybe an elderly patient that didn't have, or somebody with a neuromuscular disorder that didn't have good control. Things that are, and they also come in dry powder inhalers, and at the end I'll show you how to use all of these devices. The puffers, the technical name for those are metered dose inhalers. You can have either quick relief medicine or controller medicine in a puffer, in a metered dose inhaler. Only controller medicines, though, come in the dry powdered form. Pulmicort, Asthma-Nex. Pulmicort and Asthma-Nex are the 2 big ones right now that come in dry powdered like this. These are called reservoir methods. There's a chunk of medicine at the bottom of it, and when you unscrew the top, that activates the medicine. There's a blade that slides over the top, forms a powdery substance, and you can inhale it. There are also discus. Let's see. And this is, the medication is inside a blister, and as you turn it to activate it, and that blister pops, and you're able to inhale it. Combination medicines, these are for the more severe of the persistent asthmatics. LABAs are long-acting, they're the ones that combine the inhaled corticosteroids and the long-acting beta agonists. LABAs are similar to the short-acting beta agonists, but they have a later onset, about 30 minutes. You'd expect them to start working, but then they last for 12 hours. So they can be really good for patients that need that coverage during the day, but they should always be used in combination with an inhaled corticosteroid. Some of the commercials that you see, like with Advair and Symbicort, where it says, you shouldn't use this if your asthma is well controlled on another product, like an inhaled corticosteroid. That comes about because the LABAs it does take longer for them for the onset of them. So you don't want to reach for that by itself during a flare-up and think that it's going to immediately help you. And these are just examples of combination drugs. Advair is the only one that is specifically tested in young children. It is FDA approved for 4 and up. We do use all of the combinations with children in our practice. Symbicort and Dulera is the newest of these medications. I'm not going to go in great detail. We already talked a little bit about leukotriene singulaire. It's mostly supportive allergy therapy for patients with significant allergy components. And these are all just examples of those medicines. Immune modulators, again, they're injectable medications that would be done in a doctor's office. They affect the IgE. Again, it's an allergy to try and keep your body from responding or over-responding to certain triggers. And that's an example of that. Okay. Things to think about, and I'm going to pause for just a second with the slide, but things to think about with inhaled steroids. Parents are often, lots of parents are kind of resistant to having to give their child medicines every day, no matter what the medicines are. But particularly when you start talking about steroids, that can really cause anxiety for parents. And the way that we approach this with our families is that the inhaled steroids really only work when you inhale them. So they work in your lungs. They don't work all over your body. The steroids that you get when you have an acute flare-up that you take by mouth, they work great on your lungs, and they absolutely reduce that inflammation. But they also work all over your body, and they can have some pretty significant adrenal effects. They've been linked to glaucoma, to weight gain. So there are a lot of side effects of oral steroids that we don't want to happen. So if we can encourage parents to use those inhaled steroids every day, that significantly reduces the likelihood of the patient having to use those oral steroids that have so many side effects. Any questions about that? Okay. Spacers are devices that we always combine with metered dose inhalers, so puffers. They're plastic, and really they're called spacers because they create space. If you put the puffer in your mouth and squirt it, the bulk of the medicine goes to the back of your throat, and you end up swallowing it. It doesn't hurt your stomach, but it doesn't do your stomach any good. So if there's space between where the medicine is actuated and it free flows, then by the time it gets to where you're inhaling it, you're breathing it in. So it's going down into your lungs. And that is really the reason that you use spacers with those. It does decrease the taste of the medication, and that can be helpful, especially in children. But for people with lack of coordination, again, young children or neuromuscular patients, it allows them to be able to use these inhaled medicines as well. But it's really about creating that space so that it's inhaled, it's not swallowed. This is an example of a spacer with a mouthpiece. You get about 20% more medication with the mouthpiece if you do the technique correctly. So once children get to be about 8 or 9, usually is when you try to test them to see if they could do the coordination between actuation and breath. Before that, it's kind of hard to see, but this one has a mask on the end of it. Requires no coordination on the part of the patient. It just requires that the mask is placed tightly around their nose and their mouth, and that and a parent can actuate the medicine, or the patient can. These are just other examples of spacers. All of the ones that I'm showing you are also valved holding chambers. There's a special valve in them so that you can only breathe it one direction. You can't breathe back into it. This is the slide that I was really trying to get to. This shows the one on, I'm not good with right and left when I'm looking at it, and now it's a mirror image, so I'm really not good at it. But the mannequin that you see with the bulk of the medicine in his mouth, and then there's a big concentration of it in the stomach, that was shown to be somebody using the medication without a spacer. And the other side, you can see, if you could see really up close, there are some particles of medication in the stomach, but very few. The vast majority of the medicine has entered the lungs. So that's an illustration of why we want to always associate metered dose inhalers with spacers. Asthma action plans were recommended in the 2007 expert panel review guidelines. These are written action steps that should be given to all asthmatic patients on home management. What to do during flare-ups, how to manage their symptoms before needing to seek medical care. Asthma action plans should always address the following things. The patient needs to know how to recognize those early warning signs, those things that indicate that an asthma flare-up is on the horizon. They also need to know how to adjust their medicines according to symptoms. If they wake up and they are A-OK, no symptoms, slept through the night, no problems, it would just be, if they're persistent asthmatics, it would just be taking those daily controller medications. But say they woke up at 2 or 3 in the morning coughing, that would be where you would add. These steps would show you what medicines to add to treat those symptoms. They need to have direction on how to monitor the response to treatment and communicate that with their physician, particularly communicate any changes. And they also need to know when to remove or withdraw from allergens and irritants. This is just a sample action plan. It's set up like a traffic light. The green zone, everything's good. Just take the controller medicines. No need for any quick relief medicines. Yellow zone, just like on a traffic light, indicates that things are starting to get flared up and that caution is needed. Those would be where those early warning signs that we talked about would come in. So as soon as they recognize that, there are steps for them to take to try and get things under control and hopefully go back up to the green zone without having to seek medical attention. And then the red zone would be where those late warning signs, or if they don't catch it before then and get to the hospital, possibly where those life-threatening warning signs would be. And that has much more aggressive treatments in it, as well as an explanation for when to contact your physician or emergency medical help. Okay, so now any questions about the medicines or the disease process? Okay, we're going to move into the third objective, which is to talk about asthma triggers. So asthma triggers are allergens or irritants that when inhaled cause asthma symptoms to increase and that can precipitate asthma exacerbations. They vary from person to person, and it's really important to help families identify what those specific triggers for their family member are and then to take steps to control. And in the guidelines, medical management and trigger management are both seen as kind of equally important pieces of the pie. And I think that being in people's homes, we have a really unique opportunity to help them identify these triggers and make significant changes. The most common asthma trigger in young children are respiratory infections. There's no way that we're going to teach that we're going to ever be able to keep kids from catching cold. But teaching families about the importance of an annual flu shot. Children with asthma who get the flu are often much sicker than their healthy counterparts. And really teaching them proper hand washing hygiene. And then to avoid over-the-counter cold medicines, because it's hard to tell what you're treating. Are you treating a cough because of the flu? Or are you treating a cough because of the asthma? And those are different treatments that need to be undertaken. Smoke is another big one. We often jump right to cigarette smoke, but there are lots of sources of smoke. I've had several children this fall who came in after being at a camp out, and being around a campfire got them flared up enough that they eventually wound up being hospitalized because of it. Smoke is an irritant, and when talking to families about the difference between an allergen and an irritant, an allergen is something that is specific to the person. That's an immune response that person's body has. An irritant is something that's going to likely bother everybody. And sometimes it's good to help them understand the difference between those. But irritants that would only bother me a little bit and somebody with a really sensitive airway can bother them much, much more. Suggestions for controlling smoke. If possible, have families use central heat. To me, the hardest thing to help families figure out is if they're using like a wood-burning stove for heat, because they've got to stay warm. But in those cases, helping them figure out the best ventilation, the most appropriate ventilation. If it's tobacco smoke, have it, of course, be outside. Encourage smoking jackets, that as soon as the smoker comes in, that they wash their hands, wash their face, change their clothes, any steps that you can take to separate that person with asthma from that smoke exposure. And I kind of come down on the side that to just tell somebody that they absolutely have to stop smoking, of course we talk about that's what's best for their health, their child's health, but I also want them to have information on how to reduce that exposure if it's not realistic that they're going to quit. But smoking in a car with somebody with asthma is something that I don't think there are any techniques that you can do to reduce that. So I try really hard to give families some other things to do in the house, but that one I'm pretty straightforward that there's just nothing else. Just don't smoke in the car with your child. And then avoiding smoke sources. Teaching kids that, like, if they're out on a scout trip, you know, smoke makes it worse for you. Try staying out of that area. If you're grilling on a barbecue, keep that child or that patient away from where that smoke is flying. Just simple steps like that people sometimes don't think about until they're in the hospital. Okay. I think we've gone through all of these. Strong odors are a very common asthma irritant. Cleaning supplies, perfume, hair products, paint, candles, all of these things can cause asthma flare-ups. And really the way that you can do this is to avoid them. You know, if you know you have somebody living in your house that's really sensitive, don't clean with Clorox while they're there. Or burn candles while they're there. This sometimes becomes an issue for children at school, too. And I've done a lot of requests for 504 plans saying, can you not use strong-smelling chemicals or paint while the child's in the building or in the classroom. Dust mites are tiny insects that thrive in warm, moist environments. Everybody in Alabama's homes, we all have them. It's not really an indication of how clean or messy you are. They like to live in fabric, and they feed on human and warm-blooded animal skin cells. So beds are like the perfect environment for a dust mite. Things that you can do to reduce dust mite exposure, if it's possible, they do make dust mite resistant pillow covers and mattress covers. The pillow covers are around $10. The mattress covers, depending on the size, are in the range of $40, $50. Sometimes that's an option for families, sometimes it's not. Again, carpet is another, and particularly bedrooms, is another place that dust mites will congregate. If you have a family, it may not be realistic that they remove the carpet, especially if it's a rented home. But if they are teaching them to vacuum as frequently as they can, and then if they were to move, encourage them to find a place without carpet in the bedrooms, especially. Reducing stuffed animals, because that's another place that dust mites will get into. I often teach parents to make a stuffed animal house, and it's one of those tubs from Walmart or the Dollar Tree that's plastic and has a lid that goes over it, and that's where the stuffed animals live. If it's a really young child and they have a really special cuddly, you can actually put it in like a gallon Ziploc bag and in the freezer during the day, and the cold temperature will kill the dust mites. Washing the linens in really hot water weekly will also reduce dust mites. If you have like a carpeted house and people like to lay on the floor or on fabric or upholstered covered furniture to watch TV or something, if they will put a clean sheet over that and lay on that, at least you know that has just come out of something protected and then can go in the washing machine as soon as you're done. It's a lot easier to clean a sheet than it is to clean the carpet or clean upholstered furniture. So just more written down, and this is so that you have this information in your packet. Strong emotions are something that can cause asthma flare-ups. Crying and laughing are probably the two that I see that patients consistently have the most of. Encouraging them to take slow, deep breaths and any other relaxation techniques that work for them are good ideas when emotions result in asthma flare-ups. They can also, I've had parents who have come in to clinic and have said, oh, I can't put my child in timeout because then they'll scream and then they'll have a flare-up, and that just sets a really bad parent-child cycle into place. You can pre-treat with quick relief medicine, and we'll talk about that a little bit with exercise-induced symptoms. It's the same with that, but you could give them 2 puffs of albuterol before, or Xopenex before putting them in the corner to try and prevent that from happening. Exercise or strenuous physical activity or strenuous play can cause symptoms, but it's really important that people with asthma do exercise because that keeps your lungs healthy, it keeps your weight healthy. The most common thing to do with exercise-induced symptoms are to pre-treat with quick relief medicine about 15 minutes before the activity starts. Also, properly warming up and cooling down gives your body a chance to adjust. It's important that you, if it's a child that that all of their coaches, PE teachers know that band teachers, that's another one, know that this is an issue and that they'll need to pre-treat if that's the case and what to do in an emergency. Okay, extreme temperatures. It's winter now. Something that you can teach patients to do in really cold weather, to pull their shirt up just over their nose and mouth. It just gives your body a chance when you just first go out. So you just have a little bit of a chance to adjust before the onslaught of really cold air. In the summer, which that's where we deal with more extreme temperatures in Alabama, certainly in the summer, being outside in the early part of the day and the latest parts of the day where it's cooler can be helpful. Molds are allergens that are asthma triggers for some people. The spores are released into the air and aerosolized, so you breathe them in. Suggestions for controlling molds: fixing any plumbing leaks as soon as you notice them. And I cannot tell you the number of letters I've written to landlords about moisture issues. That's probably the thing that when I go out and do a home visit that I see most often, that is that and evidence of cockroaches, that I think, oh my goodness, every room we walk into there's some kind of moisture issue. Small amounts of mold like growing on the wall you can clean with a 1-part bleach to 3-part water solution, but that only helps if the moisture issue has been addressed. So if there's a leaking pipe behind the wall, you can wash that mold down with that bleach and water solution all you want, but it's going to continue to come back until the leaking pipe behind the wall is fixed. Avoid humidifier use. If the family has a humidifier for a specific reason that their doctor has told them to use, that's okay, but help them know that it's really easy for mold to grow in the bottom of it or along the filter, because it's moisture that's just coming up into this machine all day long. And then if it's in that filter, then it's being aerosolized. And always use an exhaust fan when cooking or showering. Pests, cockroaches, mice, rats, all can be allergens. It's really the droppings from the animals or the dander from furry animals. Or when it's not the cockroach that's running on your kitchen floor isn't going to be an allergen, but either their droppings or when they die and little flakes of them come off and fly through the air, that's actually what the person with the asthma is going to respond to. So again, moisture is a huge thing with a lot of these. Any steps that you can help the family take to avoid any kind of standing water will reduce the likelihood of any of these creatures. Always keep food containers sealed. Again, fix leaky pipes as soon as you notice them. You can also, you can put poison bait traps down, but certainly coach the family if they have young children how to do that in places that are safe to do it. There are also sticky traps that can be pretty effective. Pets, some of this is the same for the furry creatures that, like mice and rats, but it's animal dander, pet urine, and skin cells, saliva that are actually what we respond to. If you have somebody with a really strong pet allergy, of course the best thing to do is to find another good home for that pet. But if that's not, that, to me, talking to people about pets is almost as sensitive at times as talking to them about cigarette smoke. Like, these are the two triggers that get people the most, that cause the most anxiety. Certainly make that patient's bedroom an asthma-free zone so the pets don't go in the bedroom. Don't let the pets get up on furniture where the patient is going to be sitting. And always teach the patient to wash their hands and face and change their clothes after they've handled the pet. And wash pets weekly is in the recommendation, and that includes cats. And my cat, it would be bad. Pollens are little particles from grasses and trees that fly through the air. Weeds as well. Lots of people are allergic to them during high pollen times of year. You want to keep windows closed and use air conditioners if at all possible. Always have the patient's family take their shoes off when they come in so that you're not tracking that pollen through the house. If you're going to play outside before it gets really hot, because the dew will keep the pollen down on the ground. And always take a shower after being outside in high pollen times and change your clothes. Okay. Questions about triggers? You guys are easy. All right. So we're going to spend a few minutes talking about the special roles of the case manager. So these are the things that, and if you guys have been out doing this, please throw suggestions in there so that, because everybody's going to benefit from your experience. But these are these are a summary of the things that I've found to be particularly helpful when I do home visits. I always start by reviewing the child's asthma action plan with the family, and I use a combination of looking at what's written down from the physician's office as well as what their understanding of the action plan is, because sometimes those are spot on and sometimes they are not even close. I also, course, assess for any psychosocial barriers to good health care, good asthma management. I make sure that the right people, this is a real opportunity to make sure that the right people are at the table, that we're working with the important people in that child's life. When you go to the doctor, it may be the neighbor that brings the child. It may be mom, but she works all night and grandmother is with the child during that time. Being in the family's home gives you a real opportunity to see who's taking care of that patient and try to really engage them. And that's something that is a real struggle for the doctor's office. Assist the family with medication organization and establishing a good medication routine. I have been into so many houses, well, probably the best example I have of this. There were 4 children in the family. 3 of the 4 children were persistent asthmatics. The mother was a persistent asthmatic. Mother went kind of to wherever she could to get medicines and health care, didn't have a medical home. 2 of the children went to one pediatrician. 2 of the 3 that had asthma went to one pediatrician. The 3rd one went to a different one. And two of those went to a specialist of the doctors in the practice that I'm attached to. And there were 2 different pulmonologists that were working with these children. And then add to that the times they've been in the hospital or been in the emergency room, and there was a plastic tub like this, full of everybody's medicine. Wasn't separated by person, wasn't separated by what was prescribed. I mean, it was really that deep of medicine just jumbled together in this container. So I'm looking at this and I'm like, wow, I'm a social worker, not a nurse, not a doctor, but I know this is a disaster waiting to happen. So I start calling all of these doctors' offices and I'm like, you don't know me from Adam's house cat, but I'm in this patient's house and this is what I'm seeing. Can you please tell me what their current prescription is? And we spent about 3 hours going through that tub and sorting it out by person in the household and by what the medicine did, because there was no understanding. I mean, it was really like somebody was flared up and they just went and grabbed whatever they happened to, whether it was prescribed to them, whether it was a control, it didn't matter. I mean, that's just how that was going. So when you run across those, if at all possible, take the time to help the family sort them out, because that can be really dangerous. Be the eyes and ears for the physician and the physicians, the people that work in the doctor's office. Let them know, communicate back your observations. And I have patients that are that work with y'all all over the state, and sometimes I get great documentation that I know exactly what that person was thinking when they went in there, and that's really useful and can really help us make good plans for the families. And sometimes I get like one sentence, met with them in home or something, and that, well, okay, but that's, I'm glad you met with them in the home, but that doesn't help me know how to tailor stuff in clinic. And when I first started doing this, it really never occurred to me that doctors would want to know what was going on in a house. I was like, I kind of just thought, well, I'm just going to sit here, and whenever I have my opportunity, I'll throw in my little social work piece. But that plays a huge, they want these families to be successful. It's really frustrating to everybody on the team when you just see these families floundering. And physicians know that that's a big part of that person's life, or almost all of that person's life is happening outside of their office. So any kinds of insights that you can give them can be really helpful in what to do. Help the family, of course, identify asthma triggers. If they've had allergy testing done, that can be really helpful for guidance. If not, it's really talking to the family about helping them track where they are when flare-ups happen, what's going on, what's changed in the environment, as well as kind of looking at the environment they live in and think, oh, well, there's a lot of moisture in here, and they're always sicker when they've been at home for 2 weeks over Christmas vacation. I wonder if that could be what's going on. Educate the family about healthy cleaning and household management techniques. Look at special environmental triggers in the community. If the family lives like near an airport where there's jet fuel all the time, is that a strong odor, or is there something in that that's causing flare-ups? Or if they're, near a industrial complex, just whatever is in that family's immediate environment. And assist the families in working with landlords to ensure that environmental issues are addressed. I actually think it's more difficult when they own their own homes, because then it's really you just going on their financial means to be able to make those adjustments. I've had some landlords that were not helpful at all, but by and large, if you're not asking them to do huge things, they want to keep, if they're good tenants, they want to keep them in their properties, and for the most part, they've been willing to accommodate. Help students identify triggers that might be at school. Is there a difference? Does a child do better during summer vacation or Christmas vacation than they do at school? Help the families and the school. Maybe that you actually go to the school and help the school figure out what might be a trigger. Work with them if necessary to create a 504 plan for that. Some schools are really resistant to doing 504 plans for asthma. What I tell families, if the school's willing to make the accommodations that they need without the 504 plan, fine. But it's that those children have a legal right to be in school, and asthma is a chronic condition, and it does fall under 504 regulations. Always make sure that an asthmatic patient has access to quick relief medicine. If it's a child, that they have it at school or daycare, and that somebody in that school or daycare knows how to administer it to them and what steps to take during an emergency. You can certainly help facilitate that kind of paperwork between the school and the families and the physicians if that's needed. Sometimes you'll have issues that come up with children, self-esteem issues that come up around, and this is more just a common chronic disease situation. Most schools, you're going to find several kids in the school that have pretty significant asthma, and that can sometimes be helpful. But sometimes, especially if you're in a really small school, I've had this come up more with private schools where there's just one or, there may just be a handful of kids with asthma and really only one with significant disease. I've had parents go in and read a story about asthma or anything that you can. There's a great PBS, Arthur, the TV show, there's a great episode about his best friend Buster having asthma. Any of those things that you can do to kind of normalize that can be helpful. Ensure coaches and PE teachers and band teachers, especially if they're like marching band, know that the child has asthma and what to do during a flare-up. And I said think outside the athletic box, because there are like dance teams, they might not think of, oh, we're worried about the football players and the basketball players, but we're not thinking about that. We're not thinking about the marching band students. But anytime you're doing something that's physically exerting, if exercise is a trigger, that can certainly happen. Another thing that I think that as social workers we bring to the table that sometimes is lacking on health teams is to take into consideration issues of diversity and health beliefs. Once you're in somebody's home and if you take those steps to engage with them and get to know them, they're going to be much more likely to be open with you about what, maybe have one family that the aunt died of an asthma flare-up when she was like 16 or 17. And they were just convinced that, one, they were convinced that was going to happen to the child, and two, that there was nothing that could be done. So it's just a very fatalistic sort of outlook and very little trust from the physicians. And as it turned out, nobody talked to the family after the patient died. Nobody, they didn't have a lot of coaching up front, so they didn't know the things that could have played into that. But you will know those things. You're much more, well, you may not, but you're much more likely to get that sort of picture in their homes in a non-threatening, you're not in a white coat, you don't have a stethoscope, you're just talking to them than a doctor is. But for them to know that backstory, when the patient does come back in, then that physician has the opportunity, or nurse practitioner has the opportunity to start trying to engage maybe more thoughtfully and in a less intimidating way than they would ordinarily. And this all goes into it, like I said, really taking time to get to know those patients and how do they trust the medical community? Is there somebody, is there like if you're in a Native American culture, is there a spiritual healer that we need to incorporate into the plan and figure out what we can do? Are they using herbal supplements? Do we need to figure out they may really not be safe, and that may be something that we really have to address? But it may be that they're not something that's harmful and that they're going to have a lot more buy-in if you let them with what your doctor is recommending, if they are able to continue those other practices. So really trying to help negotiate that. It's also important to help for everybody to figure out who's really driving decision-making process in the families. I have one family that I've worked with for a long, long time. Mom's pretty intellectually limited, and we didn't really know for a long time how things were sort of getting done in the family. But it turned out her mother was in the home, lived with them. She'd had a stroke and didn't have good use of her legs, so she wasn't mobile and couldn't come to the appointments easily. But she was the one that was really monitoring the medication use, making sure Mom was following through with the schools. And Mom wanted that. Mom relied on her mother. So to have that piece of information, I can go back after a clinic visit and touch base with the grandmother, and we've kind of closed that loop. And advocate for your patients whenever possible, especially if it's an issue with a landlord or an issue with a school, somebody that they feel pressured by or that they see in authority, see as an authority figure that they don't want to come up against, but that really something has to be addressed. You're in a unique position to partner with them and to help them be able to do that. Also with physicians, if they're intimidated by their physicians, help them understand that they're people too, and that they deserve good health care. So all of those situations. These are some online resources that I just wanted you to have. the American Lung Association, the Association of Asthma Educators, and probably the most important one on here is that on this slide is the Allergy and Asthma Network. Mothers of Asthmatics has a lot of really practical, useful information for parents dealing with asthma and food allergies. And then for more technical information, the National Heart, Lung, Blood Institute, and the EPA has some good resources for families and kids. And the next slide is resources for kids. Use those. So that concludes the presentation part of it. Do you have any questions, comments, concerns? Okay. Well, the final part is that I'm going to demonstrate the use of the different asthma devices, medication devices, so that you will have that as a reference when you go into the homes of asthma patients. The first device that we'll talk about is the metered dose inhaler. That is, all puffers are metered dose inhalers. They are, the medicine can come out and fits back down into a plastic sleeve. It's not any of these devices that have a counter on them. It can be either in the back of the device or on the top. They don't recommend that you pull them apart because it can change the dose counter. To care for them, you just take a Q-tip and wipe out the inside where the medicine sprays out because it can become clumped. These medicines controller medicines and quick relief medicines both come in metered dose inhaler forms, and these always need to be coupled with a spacer to ensure that the deposition of the medicine is appropriate. Spacer with a mask is what is used with young children, also patients that have difficulty, maybe an MR adult or somebody with Parkinson's disease might use a mask because they don't require any particular coordination and somebody else can actuate the medicine. Once the medicine is actuated, you want to, firstly you want to make sure that the seal is tight around the patient's nose and mouth. Once the medicine is actuated, you want to watch for 6 breaths in and out. And the way that you know that the patient's breathing in and out is this flap right here and this flap right here are going to move. And so you just count those 6 inhalations in and out. Once you get to 6 deep breaths, take it off, and you're going to wait 1 minute between puffs. And that just allows the medicine to settle down from the first puff before you introduce the second puff. So this is an example of how this would be used. You do with these medicines, it does require, you do want to shake them before each puff. And when you initially use them, and you just have to look at the package insert to see the specifics on that drug, but you do have to do priming sprays. Usually it's 2 or 4, depending on the medicine. So the correct technique for this, shake it. Make sure the mask fits snugly over the nose and mouth. Actuate the medicine. And then once the 6 breaths in and out are done, just take it off and wait 1 minute. You can shake it between puffs. And it's the same process. Most of the controller medicines are 2 puffs. Sometimes quick relief medicines will be 4 or more puffs, and it's the same process. It's still the 6 breaths in and out. Take it off, wait a minute. Do it again. Okay? Unlike the spacer with the mask, the mouthpiece does require coordination on the part of the patient using it. Again, you shake it just like you do with the mask. The medicine is actuated, and once it's pressed, you start a slow, deep breath in. So it's press, and once the patient has breathed in as deeply as they can, they hold it to the count of 10. Once they count to 10, let their breath out and wait 1 minute. Also, they want to breathe out, make sure they've exhaled as completely as they can before beginning the inhalation. Shake. If you hear a whistle with this particular make, that's your auditory clue to slow down your inhalation. Different ones have different things to coach you on, but if it's an air chamber, that helps you know to slow your breath down. With these, you always want to, with any of these kind of medicines, if the patient is feeling well enough to do it, you always want them to stand up, because that just allows you to breathe in and out as fully as possible. To care for these, they come apart and can just be, you just want to wash them with gentle dish soap. Wash them, rinse them, put them in the drainer to dry. You don't want to stick like a baby bottle brush or a towel down in there, because that will change the electrical static charge inside, and the particles in the medication will stick to the sides instead of free flowing. So we don't want to create any static electricity inside this. There is one that is called the Vortex, and it's metal. And if you have that one, they can put it on the top level of the dishwasher. But if you have any questions about it, tell them to wash it by hand, because that's the only device that you can put in the dishwasher. The only puffer-like device that's an exception to the spacer rule is Maxair. And again, it's mostly older kids and adults that you would see with this, and it's breath activated. So instead of actuating it by pressing down on the button and releasing up, it's actually the inhalation that's going to release the medicine. So with this, you just push that up, take the mouthpiece off. To prime it, there's a slide on the bottom of it, and you just slide that twice. But to do the next one, you do have to flip the spring on the top up and down. That's how it's released. So to do this one, again, you exhale, flip, hold to the count of 10. So that you can hear the click in this, and that lets you know that the medication has been released. And you can imagine with teenagers at school, this is a lot more popular than this and this, because this can just go in a pocket and be much less obtrusive. The other form of, and these are dry powdered inhalers, and these are just controller medicines. The first one, when we talked about the reservoir method, where there's a chunk of medicine in the bottom and a blade that slides over the top of it, that is what this is. This is Asthma Next. There's Pulmicort also has one that's similar, and it has a device counter on the side. This is activated by twisting the cap on and off. The Pulmicort one is activated by twisting at the bottom. Things to think about with these, because it's a dry powder, they're really moisture sensitive. So coaching families to keep them out of bathrooms and kitchens is a good idea, because the moisture can get in and it'll ruin the medicine. So you drop it, and the medicine is likely to break, and then it won't be effective. With this one in particular, you have to keep the cap, because that's how it's activated. If you lose the cap, then you can't activate the next breath. And once you've used all the medicine in it, on this one, the cap stays on it. You can't take it off. So with these medicines, twist and take it off. You want to hold the medicine straight out, kind of like a sandwich in front of you. And with these, instead of a slow deep breath in, like with the spacer, this is a fast deep breath. So it's as fast as you can, and then holding to the count of 10. So it's the dry powdered inhalers, particularly the reservoir methods, are only for people who can really get the most updraft in the inhalation. They're the hardest to to actually draw the medicine out of. So they are mostly used with teenagers and adults. The discus are a little bit easier. To use these, you just twist, and then there is one final snap. The medicine's ready. Again, straight ahead. Hold to the count of 10. So the biggest difference between the dry powdered inhalers and the MDIs with spacer is how quickly your inhalation is. With the spacer, it's really slow, controlled breath in. And with these, it's you want to breathe in as fast as as much as you can, but as fast as you can. And then the final device is the nebulizer that we'll talk about. These are nebulizers. Always need, they're compressors, and you plug these neb kits into the compressor. The medicine enters the neb cup from the respule in here, and then the medicine is aerosolized when it's hooked up to the compressor. They always have to have, and I'm sorry I don't have a mask with me, but they've always got to either have this mouthpiece connected or a mask that will fit on it, which you don't ever want to see. You don't want to go into a house and have a toddler that's sitting on mom's lap and they're doing this and mom is chasing them with the medicine thinking that it's getting in. It's not. Just like the airline stewardesses when they're going through their safety checks at the beginning, they tell you, you've got to put the mask, if the yellow bag comes down, you've got to make sure the mask is over your head. Same thing, the mask needs to be attached with the elastic that goes over the head, or the patient needs to be breathing in and out like that, because those are the ways that the medicines get in, not just if they're going into the air. Most of it's going into the air. Also, and we talked about this a little bit at the break, but the treatments that you can do on a nebulizer at home are not equal to the treatments that you can do in the emergency room or at the doctor's office. When you're getting those treatments, you're getting oxygen compressed and with forced air, as well as the medication. So you're actually getting kind of a double treatment, if you will, and they're monitoring you for any side effects. Any questions about the devices? Okay. Well, thank you for letting me be here today.